Well, welcome everyone. We have about 37 participants out there, and I know this will gradually tick up. As I said that, two more came in, so we're slowly or quickly rising in our participants. I want to welcome everyone. This is hopefully part of a series of webinars or Zooms we'll have with families to help them navigate through all of this. You know, obviously, we've been talking quite a bit at school committee meetings and on the family forums. We were lucky to have a couple of psychologists who were wonderful on Friday speak with us. And here we have our district doctor, Dr. Stephen Golden, and one of our public health agents and our town nurse, Mary Goodwin, along with the Director of Student Services, Barbara Sawanka, and myself. Of course, I'm Pat Sullivan, Superintendent, here to help work with you to answer some of your questions as we all work together to try to navigate through this and make it as safe as possible for our kids and for our staff, and that families can have security in what we're doing. So to kick off into it, I guess I'd just start asking Dr. Golden. Again, thank you, Dr. Golden, for being here and for helping so much, and obviously Mary for all the work you do. Mary, we are very closely connected to Mary as a school in regards to anything that happens health related. You know, obviously when we had a situation with, there's Dr. Scollins coming on in, but as we had a situation with a mumps situation earlier this year, Mary was very helpful with that. Any major health issue that happens at the schools, we're able to really transfer through Mary to give us some help. So Mary will be here, of course, to talk as we have questions. But I will turn it over to Dr. Golden. I see that Dr. Scollins has joined us, so thanks for persevering through that. Dr. Golden and Mary, this is Dr. Scollins. Haven't met her?
Yep.
Okay, I'll continue, Leslie, because your audio is kind of coming in and out. But I'll start with Dr. Golden, maybe just talking a little bit about what the disposition of this particular disease does to schools in terms of how it can create obstacles for schools. And then what are some of the safety elements that you think are important for schools to put in place as we think about bringing kids back, and talk about anything you'd like in terms of the importance of bringing students back and what we need to do to be measured to do it safely. So thank you.
So, a couple of things to start off with is anytime I guess somebody's giving any kind of a medical opinion or discussion, they try to say they have no financial ties to anything. So I really have no financial ties to anything. I am the school physician or the district physician for the town of Cohasset, but I've had several discussions with both Dr. Scollins and Dr. Sullivan, and in no way, shape, or form has anybody twisted my arm and said, you need to say this, that, or whatever else. So I really will share opinions. I'll share some data, and I will also leave people with the thought that I'm thinking there's going to be a question and answer period, at least I'm hoping to be, because I have not extensive remarks myself. But in the question and answers, if I don't have an answer, I will let you know that, and I will try to find an answer for you. I've got some resources in infectious disease and immunology experts, and I know there's a mechanism to get those answers back to you if I don't have the answers myself, which is frequently the case. I did look at some different sources, the American Academy of Family Physicians, the American Academy of Pediatrics, the CDC, the Mass Department of Public Health, and also some other databases that try to get some information together that seem to be consistent, which is anything what this coronavirus has been. There's been very little consistency, very little definitive statements, and that's what made it quite difficult. We deal with strep throat. We know that if somebody has strep throat, we can treat it, we can make them better, we can prevent complications, and we can usually have them be non-contagious 24 hours after treatment. So the school nurse has an easy time to deal with that, and the medical community has a good, easy time to deal with that. There's been nothing easy about this coronavirus. It's changing, it's morphing, the information about it has been inconsistent. Unfortunately, in an election year, it's become a little bit of a political issue, if not a huge political issue, and it's become a high-level news issue, which I think only has added to the uncertainty and, I don't want to use the word terror, but certainly some anxiety from everybody, whether they're clinicians, parents, children, and so on and so forth. A little bit of background, I've been here in the community for almost 40 years in practice in Cohasset. I've been involved with the school system both as a physician, a member of different groups or clubs, 3 children who went through the school system. So as a parent, I understand people's concerns as well. I have a fair amount of pediatrics as part of our practice. So I'll try to keep my comments after this brief, to the point, and evidence-based. And that's really the start of this. And you see me looking over, I've got a few notes that I wrote down. So that was from the top of my head. The return to school guidelines have been stated as being evidence-based and flexible in response to new information. So I think any program that we develop, any things that are determined to be important, needs to be evidence-based, which frequently stuff that's had to do with coronavirus has not been, and flexible. And as we all know, things have changed sometimes day to day with it. And as schools implement, this different types of things that they might be doing, I think that's important to keep in mind. What's true today may not be true tomorrow. I think an intensified disinfection system is going to be an important part of this. But it's not a substitute for vigilant hand washing, proper use of face masks, and practicing physical distancing, which I guess is the morphed term of social distancing. So I think that people should take this seriously. And I guess I should also give you some background to say that our whole office and group has not been a group that's been terrified by this. We've been open every day since the start of this. We've seen patients in person and through telehealth throughout this entire pandemic. We've had no cases that have come into our office who have developed COVID-19, nor have we had any of our employees in our office develop COVID-19. And I don't think that's because we've been good at anything. I think we just jumped on this. We provided the type of health care that was necessary to provide. And we kept in mind, as I think everybody in the school department should, that this is only one disease. Yes, it's big right now, but there's other things to take into consideration, both from a developmental point of view in the school system and also from a medical point of view. In late June, the American Academy of Pediatrics released a statement and stating that with a number of caveats, they strongly advocated all policy considerations, this is a quote, for the upcoming school year should start with a goal of having students physically present in school, okay? And I think that's an important concept, and it's part of the concept of the risk and benefit. There's a risk and a benefit to not being in school, and there's a risk and a benefit to being in school. And, I've been asked the question once, do you think it's safer for me to send my child to school, or is it safer to keep my child at home? Well, if you're just thinking of safety and you're thinking of transmission or possible contagion from this virus, everybody knows that answer. You're better off at home. Okay, it's a more controlled environment. But is the risk so high that you can forego the benefits of the in-person physical education? Again, one of the things that came up in my research is obviously that's a decision that a parent needs to make. They need to weigh the evidence from information like this, from other information that they glean, and then make that decision. I think this has been somewhat of a unique disease in the history that I've seen. And, I obviously was in practice through SARS and MERS. I've seen whooping cough epidemics, when chickenpox, we used to see chickenpox. And I think that this is different in that many individuals have heard so much in the news, read so much in different media outbursts, and also looked at different types of resources which are available now with computers. So they may know more than I do, more than another clinician does, or at least feel that they are as informed. And that's fantastic. Good information is really very valuable. I think that old thing about if it's on the internet, it must be true. We've just got to keep in mind, because not everything that you see, hear, and read is necessarily evidence-based. John Andrews is the AMA's Vice President of Graduate Medical Education. He happens to be a pediatrician, and he's weighed in on this. And again, his feeling is it is important to recognize that, and I will quote him, parents make independent decisions. This is what I alluded to before, and that is that, the ultimate decision is, whether a parent wants to participate in whatever is offered. And I don't know what the school's position is on this, but certainly that's the medical opinion. He questions whether some behavioral risks of keeping students at home may even outweigh the physical risks of having them in school when you look at the data and the information. One of the things he stated is that the data indicate that children appear much less likely to contract the disease, and when they do, they tend to recover well. Further, the spread of the disease from asymptomatic children to other children or adults seems to be relatively uncommon. Now, this statement was made in July. We are now in August. I know there's been some reports that transmission from children is felt to be higher than one thinks. But I think that what ends up happening is one person or one entity does a little bit of research, a small, probably not validated study, and comes out with a statement. So I think a lot of misinformation has been out there. And honestly, I'm looking at the same misinformation, and I'm trying to make my best decision as I conduct my practice and as I conduct advising you and talking to you this evening. I think that his thing is communication is hugely important, and I really think it's great that the school superintendent and assistant superintendent have offered a number of different sessions to parents, a number of different sessions now with some medical input, and also offering that same input to staff. I don't think that probably happens in every town. I don't know for sure, but I really think that that's a real good thing about what's happening in Cohasset right now. There's been a lot of talk about the disease in disparate populations, underserved populations, populations of color. I think that this is an important thing to look at, and trying to mitigate that is very important. I think that is something obviously the school system will be looking at and dealing with. Another thing that came up was a statement that policymakers and school administrators should acknowledge that COVID-19 policies are intended to mitigate, not eliminate disease. Nobody is going to think that we're going to eliminate disease, eliminate risk, or even eliminate any exposure. But I think that what we can do to mitigate and to minimize that is very important. There were a number of other things that I outlined. I do have some, I guess what is probably the most recent information on the town of Cohasset. Mary, you might even have that at your fingertips, so I don't want to
I do.
go into something. So, okay, to leave that to you, and I can comment afterward.
Sure.
So I think that in short, I think that the biggest things are trying to disinfect as best as possible, trying to limit exposure as best as possible, and trying to not stray away from the basic tenets which have been outlined of hand washing, face masks, and social or physical distancing. So I think that can we depend on our children to do that? I think we hope so. And I think emphasizing that importance both as administrators, staff, local medical community, and parents is going to be very important.
Thank you, Dr. Gold. I don't know if Mary, if you wanted to talk a bit about where Cohasset stands right now, that'd be helpful.
Sure. So I'm Mary Goodwin, the public health nurse. I've been your public health nurse for 12 years. I've been a registered nurse for 42. So I'm only 39 years old. But anyway, I live in Cohasset. I raised my family here. My girls both went to the Cohasset school. So I know the system well. I have a good working relationship with all the school nurses. When the schools shut down in March, they all offered their assistance. They lined right up and they did help with the contact tracing. So the way the system works, I get a report of a positive COVID case. I contact that person within 24 hours, and then we identify who they've been around, who are their close contacts. And from there, you reach out to those contacts, and then they're placed in quarantine for 14 days. And the reason we do the 14 days is because this particular virus, you can incubate or sit on it for up to 14 days. So it's really important that you stay home and quarantine for the full 14 days. So to date, as of March 1st, we've had 29 cases. We currently don't have any active cases, and of the 29, 27 have recovered. So our infection rate is pretty low, which is what the schools and the state are advising us to look at when we think about reopening schools and how to reopen them. So, and that's something that I will work closely with Dr. Sullivan and school nurses in terms of cases and when a decision will be made if we should continue with school. So that's my role in this whole thing. I'd just like to really reinforce, as Dr. Golden said, it's wear your mask, physically distance, wash your hands, try not to touch your face. And I think if we can hammer that home to kids, that will really help a lot with how we do with in controlling the virus. So basically, that's it.
That's great. No, thank you, Mary. And your work with us is so appreciated. You know, right now we're operationalizing all of the protocols and from the CDC that are present in our roadmap with our school nurses. I know our school nurses have worked a lot with Children's Hospital in their programming to create the protocols that our staff will see and our certainly our families and students will see in the coming days. I do have a question here from someone, but I'd just open up by just asking this question. I think it's sort of a general question that I know that I've heard many times from families is, I think there's some anxiety regarding what can and can't happen in the school building and then outside, and what the differences may be in terms of wearing a mask or in terms of, you know, if a teacher or a kid gets close to another kid within 3 feet, say, or 6 feet, as some would say, even wearing a mask, what are the dangers in transmitting the disease at that point? And then when you're outside, you know, there's a more sense of obviously better ventilation, and the guidelines are a little bit more liberal in that people can take off masks at a certain distance away from each other. So maybe talk a little bit about, Dr. Golden, about if you would, kind of what are your views on those fears and those misconceptions, and how one might want to navigate through that?
I should have mentioned that before. So a couple of things that started with the onset of this pandemic was the thought that this was a virus that was not transmitted as a aerosol with normal breathing. For anybody who's old enough to have had chickenpox would be termed highly contagious. Chickenpox, you go to school in first, second, third grade, one child comes in that's infectious, and 95+% of the class has that within the next 7 to 21 days, which is the incubation period for chickenpox. All they've got to do is breathe it's aerosolized in the environment, and the contagiousness, as I said, is enormous, okay? If that were the case for this coronavirus, there would be tens and 100 million cases by now. It's not felt to be transmitted that way. It was felt from the beginning not to be transmitted that way. And nothing that I am aware of has changed that, but it is contagious. There's a significant contagious feature to this. And the fact is, it's felt to be by, excuse me, droplet nuclei as opposed to aerosolization. Now, can you get aerosolization from droplet nuclei? Droplet nuclei would be somebody who's breathing out in an exhausting manner or coughing or sneezing, and that projects a certain distance, okay? It's felt to be about 3 to 6 feet. There has to be a significant amount of contagious material. There has to be an exposure of a duration that would make that contagious, and it would have to enter into your body, not through your skin, but through an orifice, the mouth, the nose, or a membrane like the eye, which is why, again, face shields are used in a highly aerosol environment like an intensive care unit caring for COVID patients. So the notion of just a spread in the classroom with somebody breathing just doesn't, or at least we don't think it does today, occur. Obviously, with better ventilation outside, that's more helpful, but I think all of us have had situations where we wonder, you know, could somebody have given me this? I tend to do a fair amount of bike riding, and bike riding, and 30 feet away, two people are walking in the opposite direction, and they start running away from me, thinking that me exhaling while I'm bike riding, they're going to get the disease. It really doesn't happen that way, or else, like I say, there wouldn't have been 29 cases in Cohasset. The entire town would probably have the disease right now. So it's not that you've got to really try hard to get it, although there has been some thought in that area. But the idea is that with proper measures that have been taken, it is not felt to be, in that term, highly contagious like a chickenpox virus. So with distancing, with people not coming to school, with fevers, coughs, lots of sneezing, that's very helpful. One of the things that's done in most outpatient primary care offices now is if we see somebody with asthma, normally if they were having a difficult time, we might give them an aerosol breathing treatment here in the office. Well, we don't feel we're equipped to do that, and we send them out and have them be seen in a hospital setting. So we've changed our things, and we try to be nimble as well, taking care of people. And I would suggest, again, that anything that would be aerosolized, I don't think there's been nebulizer treatments given by school nurses, but certainly if there has been in the past, that would not be occurring now. I think that it's, I think it's a relatively safe environment, especially if the prevalence in the community is low, which, as Mary pointed out, it is, and if the proper precautions are taken in trying to decrease the transmission if there is someone who's completely asymptomatic, without fever, doesn't know they have anything going on, which can happen, to still prevent the spread by limiting the possibility of aerosolization and maximizing the possibility of cleaning, washing, and masking and physical distancing.
Great. Dr. Golden, we do have a question here. I'll just go in order. The first one is, what recommendations can you make for us to follow while microschooling? So that's a phrase used. A lot of parents are maybe creating a neighborhood pod or group of kids who might be learning on a remote day and working together. So the question is, multiple kids in the same cohort schooling together in private homes on days out of class. So the question is about recommendations you can make as far as cleaning protocols, et cetera. And I would think from your point of view, ways that they can mitigate the spread, and probably similar to what you've spoken about, but anything.
Good question, and I think what we should be doing is mimicking what all environments are doing now. The cleansing with concentrated alcohol solution or bleach. And that's not drinking bleach, by the way.
Yeah.
Got to introduce a little humor to this subject.
Right.
The physical distancing as much as possible, the hand washing in the environment, using cleansing solutions on doorknobs. Now, can somebody who, let's say, is positive for the coronavirus, doesn't know they don't have a fever, they're completely asymptomatic, they're at your home in this microeducation environment, and they're wiping their nose and they touch a doorknob. Well, how long does the virus live? Well, again, a number came out of 14 days when a cruise ship came in and they identified virus 14 days later. There's a difference between identifying virus and identifying live or contagious virus. So we don't think it stays an extended period of time. I don't think anybody knows exactly how long, but certainly if somebody has a mute hand and touches a doorknob, it'd be nice to wash that doorknob. Whenever somebody touches it next, it's sanitized and inactivated. I think that trying to make sure that the folks that come into the school environment, both from an educator point of view, I guess, and a student point of view, are afebrile, meaning they don't have a fever, they're not sick with an illness, and they have not had known contact with anybody who has had the disease COVID-19. I hope that's answered the question.
No, I think that's very helpful. I think it was a really good question because I think a lot of folks
It is a good question.
Were wondering about that. Thank you for that question. The next question is, in previous years, there is a focus on sanitizing hands at the schools, at lunch, recess, and in the classroom. Is a physical hand washing a better option than using hand sanitizer? And I guess the next part of the question would be maybe for me or Dr. Scollins. If so, will there be more of an opportunity for the students to wash their hands with soap and water efficiently throughout the day? So I guess I'll start with my end of that and then turn it over to you. There will be. We do believe it's easier for students just from an operational standpoint to use a hand sanitizer because of the effort it takes to bring them to the restrooms to be able to wash. There are elementary classrooms with sinks in them, and that's helpful. And I'll be interested to see what Dr. Golden says about this, but I do believe I read that the process of actually washing hands and the actual practice of it and the amount of time you spend doing it actually is very helpful in getting rid of the disease. I guess the question is, how effective is hand sanitizer? Is it effective enough? So I guess I'll leave that to you, Dr. Golden, about which is a better option. Are they both good options, or what are your thoughts on that?
First of all, I think that's a very good question. I just jotted it down, and I will actually leave a definitive decision of that if there is a better to me talking to my infectious disease colleague. That's the first thing. Second thing is, as we know now, both are very good options. Okay, I'm sure everybody's heard the 20 seconds of hand washing. The thing about hand washing, and I actually just took a flight recently to visit family out in the Midwest, and you're in the airport, you're at a sink, and when you stand there, you can get automatic soap, you can get automatic water, you can get blow dry, or you can get automatic paper, and then the doors don't exist, so you're walking out and not having to touch a door. So one of the things about, I guess, going into a men's or ladies room in the school, I would think there's doors there. So once you do wash, once you do dry your hands, are you then touching a doorknob? So that would be one question. The other issue is, you know, even when you're using hand sanitizer, most of them are pumps, and you usually go in with a dirty hand and you come out with a clean hand. So I don't think anybody's going to be rushing around trying to do that. But can you, you know, use the heel of your hand? Can you stuff like that? I think that the other thing is, to track this. Let's say you're talking about hand to door to hand transmission. First of all, there has to be a transmission to the donor's hand. Okay, that has to be in the way of, you know, using your hand to block a cough, using your hand to rub your nose, with, so on. Then that has to touch a surface. The virus has to be labile on the surface and have its, you know, contagiousness maintained. Then somebody has to touch that and adopt the virus into its skin environment. But even then, it's on your skin. You don't get the virus through your skin. So then you have to rub your nose, you know, put something in your mouth, touch your eye. So obviously it can happen, but there's a sequence of events that has to take place. I think both are great options for sanitizing. And I will get back to say if there is a preferred in the infectious disease community.
That's great. Thank you, Dr. Golden. And we do have a really pretty heavy supply of hand sanitizer right now. I was told up to 60,000 applications, and we have over 80 applicators throughout the main areas in our buildings. We are asking, and in classrooms, of course, we are going to be asking students to bring these 2-ounce hand sanitizers that they can use on their own, so that way we're not pumping and they're kind of using it for their own purposes. And we do have protocols in place where we're going to be cleaning hands, whether, you know, coming out of recess, coming out of lunch, of course, but before, as we move into every class, some sort of hand sanitizing. So we do have protocols in place to hopefully mitigate the spread using both hand sanitizer and washing hands. The next question is, where does the medical and scientific community stand with the development of a rapid test for the virus? It seems that given the unknowns surrounding the virus and its long-term effects on the human body, deploying an accurate rapid test seems to be the best way to create safety in the general public. And I will add, before you answer this, that the guidance from DESE that just came out says that they will have mobile rapid testing units available for those districts, and I hope we're never in this situation, but that do have outbreaks. For instance, 2 on a bus, or 2 in a classroom, or multiple teachers teaching in a school. So I know it's out there. What are your feelings on that, Dr. Golden or Mary or anyone?
I'd love to have Mary take this one, but I'll take this one. I think that all we hear about, and I think one of the best things that happened to me was about 10 plus weeks ago, I stopped watching any news. And it was personally gratifying, you know, to not have to listen to that anymore. I still, at least 1 or 2 times a week, I'm on a webinar just for a medical information type of thing. But let me tell you that you hear testing is the solution. It may be the epidemiologic solution, but we don't feel it's the information solution that we'd like it to be. We'd love it to be really good. The lower the prevalence of the disease in the community, the more falsely positive and negative will be the testing in that community, if you follow that. In other words, there are rapid tests available. They can be available within less than 15 minutes. Abbott, for instance, makes one, and our entire group of Healthcare South is going to be getting some of these for the purpose of testing for when people absolutely can't go to work unless they've been tested. They can't go to whatever school until they've been tested. They can't go to college until they've been tested. We recognize that the false negative rate, and that's a very difficult thing to swallow, is anywhere from 30 to 50% with a lot of this technology. So if there's a false positive and you've quote unquote diagnosed someone with COVID-19 and then go ahead and confine them to their isolation for 14 days, it's probably not as bad as a false negative where you've told somebody who actually has disease that they don't, okay? So the testing is not great. It can be, I guess, deemed harmful. I guess I don't look at it as harmful. I just look at it as not being as useful as I would like it to be, although we will be employing some testing soon. We have not done much testing historically. The molecular testing, which is state of the art for the coronavirus, is it seeks out the RNA, the actual RNA on a molecular level of the virus. Now, that you would think would be foolproof, but it's not. It still has this false negativity rate. And furthermore, there can be remnants of RNA weeks or months after somebody's had the virus. So is a positive test really meaning that somebody's contagious? There are antigen tests, which are probably even worse as far as false positives and negatives. And then there's also antibody testing. That would be a blood test. The antibody testing, again, is not completely and totally specific for this SARS-CoV-2 virus, but any coronavirus, which is also responsible for many common colds. So again, a false positive rate can occur with that as well. The other thing is, how long do you maintain antibody and does it wear off? We don't know for sure. And there's just been a lot of uncertainty with this, which is why it's been so vexing to the medical community.
Great, thank you. And thank you for the question. Dr. Golden, how do you feel about preschoolers and their level of contraction risk and lesser ability to social distance? It's really a question about the younger kids and, you know, the fact that we may not be able to, well, it's going to be more difficult, of course, to install some of these mitigation strategies. What are your thoughts on that conundrum?
You stated that right. It is a conundrum. It's felt to be the least vulnerable population. It certainly is the population that, if there's a word impossible that could be true, it's impossible to have them physically distanced. It's impossible to have them adequately hand washed and so on and so forth. And that is such, in my mind, a unique parental decision. I guess what I would, you know, and I've been asked this, and I've been asked it by actually one of our nurse practitioners who has preschool or daycare age children. And that's opening, you know, I guess August 31st or September 1st. And I guess all I can tell you is that her parental, not medical decision, was to try to find a nanny and not have the kids go into that situation. I think what's tough is no matter how much we might say that the younger population is not as vulnerable, it's not as spreading, it's not as severe in illness, it's that younger population that when they visit with their parents, grandparents, great-grandparents, that may be vectors of the virus, and nobody wants to see that happen in a family. So I think that that's a really, really tough question, and I don't think you're going to get a definitive answer other than what I've just said, which came from, you know, some research done in the past week. Right.
Thank you, Dr. Golden. And I would say that for those of you who are really interested in the idea of our pre-K, K, and first grade students wearing masks, that the school committee will be voting on that with this coming Wednesday's meeting. So if that's a real interest and concern of yours, please be there and voice that in that meeting. Thank you for that question. Next is, probably more for me, but will parents receive some sort of weekly or consistent update on active new cases in the schools or any other sort of data points that can be shared with parents? Yes, as you remember in the spring, I did share every week an update on where our case count was. That came right from the town. And that was as we were surging in March and April. And as we've had it more controlled throughout the summer months, somewhat here in Cohasset, obviously now for sure. Our updates have been a couple of weeks apart. You can definitely expect a more week-to-week update from me, because I know people will be real mindful of it and focused on it as we start school. So yes, and I'm also going to try to do more chats like this to answer any questions folks might have. I'm picking probably Thursday nights, and that I will bring folks on with me if there are particular issues that are of concerns to people. So you can expect that as well as the continuous newsletters. So thank you for that question. Next question is, I understand that COVID might not be as communicable as other afflictions, but isn't it the case that the numbers to date have been compiled when school was closed, so we don't know what the numbers will be when school opens? And isn't it also true that there are treatments for things like chickenpox, etc., whereas there isn't a treatment per se for COVID-19?
A good question. Certainly the information to date, probably other than the first probably 2 to 3 weeks when there was some uncertainty what different schools were going to do as far as shutting down, virtual learning, hybrid models, whatever were being done. So there probably are not great data points right now. And I think that's why it's going to be so important to watch this very closely as schools open in whatever form they open. And as I discussed before, being very nimble and capable of making change. As far as treatment, most viruses in history, certainly when chickenpox was in epidemic form, there were no treatments for chickenpox. There was also not a death rate that approached the disease of COVID-19 back in the chickenpox days. Now there's a chickenpox vaccine, so we should not see that of any significance in the future. There are antiviral agents now. I'm sure everybody's familiar with remdesivir and its role or lack of role, depending on what viewpoint you want to have with this coronavirus. But I think that I'm honestly not sure if I've dissected the question properly, but could the contagiousness be underestimated? Well, I think we've got a lot of other things to go by other than children in the classroom, but if you look at elderly people with immune suppression, with disease debilitation, and the spread of disease in older healthcare facilities like nursing homes or skilled nursing facilities, certainly you can see the spread there. So it is contagious. It's just not contagious on the level of what chickenpox was historically. So I guess I'm hoping I conveyed a proper analogy, just looking at contagiousness, not looking at seriousness.
Good, that's very helpful. Thank you. So next question is about choir classes in particular. It says, and I have the guidance here, I was getting set up because I cheated and looked ahead, but it says for choir classes where children will be singing, is there a different protocol that should be followed? For instance, should the children be further than 6 feet apart? And any ideas about the ways to protect the instructor of these classes? So obviously I'll let the doctor side in a sec, but the guidance that we have, which is in the roadmap, talks about the idea of singing carrying a higher risk in terms of the outspray of micro droplets, I guess you call it.
Yep.
And it does talk about the idea of trying to do this outside if we can, keeping students in one direction, monitoring the volume of what they're singing as well. So, and it's the same thing with instruments, when we do have the opportunity to have these types of lessons, and they are important to us, that we make sure that they're outside, they're spread out. And when they're inside, we might turn to some other type of music education. It's important to know that at all of our levels, particularly the middle and the high school, we have music theory, we have music appreciation type courses that we can actually work with kids on, and learning about music in ways that doesn't involve projecting and singing. And, we'll explore those remotely too, when we have those opportunities to teach that remotely. So there's a lot of things that we'll try to do. A couple of factors that help us with instrumentation is that we don't share instruments here in Cohasset. There are a lot of school districts that do so. And, we believe that we can spread them out properly outside when we need to. So thank you very much for that question. Anything you want to add to that, Dr. Golden? I know it was really meant for you.
No, I think you did a great job. I think that there's no question that more forceful breathing, like coughing, singing, sneezing, will certainly expand the sphere of contagiousness. And I think anything that can be done to limit that or mitigate that would be good.
Mm-hmm. So this next question would probably be Mary may have an answer to this as well as you, Dr. Golden, because it talks about a little bit about HIPAA and what we can tell people and can't tell people. The question is, what type of information will you be providing to the school community if a positive case occurs in the district? Will you be reporting the specific school or grade levels? This is a particular situation where I would lean on Mary and Pam Fahey to help me kind of guide me through this. I don't know, Mary, if you want to give that a shot.
Well, we have to treat it like we treat all communicable diseases, and we have to respect and follow the HIPAA laws. If we identify a confirmed case, certainly I will be working with the school nurses to do the contact tracing. In terms of releasing that actual data to the public, I think that's something that we haven't really figured out yet, Pat.
That's fair to say. That's exactly what we'll have to collaborate on. And, obviously, we all know we have to follow HIPAA. We have to be careful with that. But then there are items that are of public knowledge that, the public needs to know because of safety reasons. So we'll follow every health guidance that is brought our way when we do have that situation to give people as much information as we can without breaking any rules around that.
Yeah, the other piece to that is if we identify a case, we certainly will reach out to the State Department of Public Health for further guidance on what they recommend. I also work closely with them. I call them often to, run scenarios by them, and they advise us on how to approach and deal with things.
So this is another question I think, Mary, you'd probably be best to answer this. This may have already been answered, and I don't think it has, so I'll continue with the question. But what happens if a child in a classroom contracts COVID-19? Does the whole class and the teacher need to quarantine or get tested? And then what happens in the school?
That's a good question. So what will happen is, like I said before, I will work with the school nurses. We will work with the teacher to find out who is within 6 feet for 15 minutes. That's the criteria we use to identify who a close contact is. Those close contacts, then their parents will be notified and they will be quarantined for 14 days. The actual case, the person who has the COVID is isolated for 10 days. So it's a little different there, but yeah, we'll work closely with the school nurses to identify the contacts. And so that's the whole idea with trying to keep the students in cohorts so that we're not quarantining an entire class. We can figure out who is in that group and when, and we'll go from there.
And Mary, maybe you could tell the folks about what the definition of close contact is at this stage, because I know it has shifted recently.
Well, a close contact is anyone who's been within 6 feet for 10 to 15 minutes. That's the criteria we use. Whether they have a mask on or not, it's the 6 feet for 10 to 15 minutes.
And do you know, Mary, then you may not know this, I don't know this answer, it was a question I was going to ask you, but is that a duration of 15 minutes, or is it over a period of time?
It's a duration, right, Dr. Bill? It's a duration, yeah.
I think that's a true statement, Mary, yeah.
Yeah.
Okay, good question. A question that I've been asked in the past regarding masks and oxygen intake, and the fear of some parents that masks can cut down oxygen intake. And maybe there's not an exact answer to that, but I'm wondering what your feelings are on that, because I know it's been brought up to me a few times of parents concerned with their students wearing masks because of oxygen intake.
So I'm understanding the question. It would be that, do you have a decreased oxygen intake when wearing a mask? I think
Yes.
with certain types of masks, it isn't that you have a decreased oxygen intake, you have a decreased intake of air, which contains the oxygen, okay? The mask doesn't filter out oxygen, in other words, okay? I think most of the surgical masks that I see people wearing, it seems like 90% of the time, certainly the gaiter masks that I see people wearing, I wear a surgical mask all day long here in the office, and I've been here, prior to probably till 5:45 when I got on here, and I was in at about 8 o'clock this morning, and I don't think I'm suffering, and I'm of an age where I think I would suffer more than a 8 to 15-year-old. So I think that that's not a real concern. Now, if somebody has cystic fibrosis, somebody has, for whatever reason, some type of interstitial lung disease, if they've got a congenital cardiac abnormality that causes them to be at a relatively low oxygen in their circulation to begin with, whole different story. But for most young, healthy children, I don't think lack of oxygen, I think a nuisance factor, itchy nose, sore on the nose, sore on the cheek. There's nothing real fun about this whole thing. But I think as far as depriving somebody of oxygen, that's not on my radar screen for a young, healthy person. For teachers, I know this isn't a teacher session necessarily, but for teachers who might be more having chronic obstructive pulmonary disease, if they're of a certain age and a certain background, again, a different story.
So we do have teacher sessions set up for later. That'll be great when we're able to chat with them as well. Our water fountains, this is for me, I'll just answer quickly. Are water fountains going to be open? If yes, how will they be cleaned between uses? We were talking about that today, actually. I was talking about that. We do have those, I'm missing the terms for them, but we have from a CEF grant, a more sophisticated water bottle filler. There's a name for it. It's escaping me. Those are a better method of getting water for students, I believe, in terms of hygiene than actually leaning in and drinking through the water fountain. But that's something that we are considering because we talked about it today, and we'll have an answer for that, and I will get that out in future information. Thank you very much for the question. But again, those CEF-sponsored water filtration systems where a bottle can go under, which are, I think, a much safer way, are going to be in all of our schools coming this year. Will the school recommend specific types of masks for the students to wear at school? If a student comes in with a neck gaiter, will it be recommended to change their mask? Well, we will be talking specifically, and that's, again, masks and our policy around masks. It is a policy, and it's going to be brought up and discussed at this coming school committee meeting. I have personally seen data around the gaiters, if you know the mask that comes up, or at least, I don't know. I honestly didn't look to see how peer reviewed the study was or anything, but I have had some information I've read regarding those as actual potentially not helpful because of the back and forth motion of the mask. I don't know how scientifically appropriate that comment is, but we would be issuing the fact that it needs to be a 2-ply or a heavy mask, and I guess the rule is that you can't see through to be able to make sure you cover the face and nose with the mask. But I don't know, as we get that information out, Dr. Golden or anyone, any thoughts on that? That's a really good question and one that we're considering for sure.
I'm certainly agreeing with what you just talked about. The gaiter masks, which are frequently very, very thin, certainly are more comfortable, but probably are not nearly as protective. And I think everybody's probably aware of the fact that it's less about how it's protecting you and more how it's protecting everybody else who's around you. So if everybody's wearing the same type of mask, and as you say, a mask you can't see through, and supposedly it would be a mask that you can't blow out a candle with. Although depending on who you are, I've seen some people with a standard surgical mask, which certainly is at least a 2-ply mask and certainly can't be seen through, still blow out a flame. But I think that, again, for normal breathing, you're not blowing out a flame.
Great. That's a good, very good question. Another question about masks is actually identical. Sometimes this happens is you have people on the same wavelength moving around, but basically I think you answered it as about neck gaiters, and they actually referenced the study that I saw about that they must have seen as well. Another one is, what would you recommend for students with asthma and or sensory issues? So there are some, the guidance that we received, Dr. Golden, from the DESE, which comes from CDC, is that students who have sensory issues are documented, and maybe an asthma or a pulmonary lung disease, or as you mentioned, it would be more appropriate for them as a potential, and I guess the data is it's not as good as a mask, but a face shield that kind of went around the edges of the neck. I don't know what your thoughts are on what your advice would be for students in this category.
So really good question. And again, I guess you could stratify the type of asthma. If somebody has moderate or severe asthma, I think that wearing a mask might be deleterious to them. I think that if they have mild, and in particular mild intermittent asthma, whole different story. I think they would probably still do well with a mask. But again, that's something that each family is probably extraordinarily familiar with at this point in time, where we're months and months into this pandemic. Certainly it's a legitimate concern. The sensory issues as well. I think that the shield is absolutely better than nothing. And the shield does a very good job blocking actual secretions and probably air movement. So again, I will jot that down as a question for my infectious disease colleague and see if I can come back with a bit of a more concrete answer. But I think that what I've said, I think, is at least valid in those populations.
Just so folks know, this recording will be posted. We'll be able to make sure we get that out there. And what I will do is when I do my Friday communications, I will make sure that if Dr. Golden is able to provide me with more detail about a couple of questions that he wanted to look into more thoroughly, I will get that out there when I do have that information.
So not to interrupt, but that was a response from my infectious disease colleague. And I said, is there any evidence for hand washing or use of sanitizer being a better mitigation technique for coronavirus? And the answer was no, both highly effective.
Very good. That's great to hear. Thank you for that. And please thank your colleague.
Will do.
Question here. I understand the point about testing protocols for if students are exposed to a COVID positive individual and the 6-foot measure for 15 minutes as the means for it, or other individuals needing to be tested. However, I want to understand this measure, as I thought the guidance for desks in a classroom was only between 3 to 6 feet as schools allow. If so, doesn't that mean there are quite a few immediate individuals who would automatically need to be tested because desks are closer than 6 feet apart? So, I mean, I guess it depends on where your desk is, I guess I would say. If students are going to be more aptly there. I mean, even at 6 feet for, a period of 15 minutes, I'm not trying to act like I'm a medical doctor, but just from a logic perspective, I would think that they would be a close contact as well, because that's close enough. I mean, if they lean like this, they lean back. Correct, Mary and
Right.
Dr. Or,
Right.
so, I don't think I think there's the idea here. What I got from it, from an operational standpoint, is that with the previous guidance, the whole class was going to have to be quarantined. And with this most recent guidance, and maybe quarantine's the wrong word, but with this most recent guidance, it might be just an individual in the classroom, or maybe no individuals in the classroom. Would that be accurate? Mary and Dr. Golden?
Yeah, I think that's fair to say that. I think, again, it's going to be case by case, right? And we'll have to figure out, who was in the class when. And so it's going to be a lot of collaboration with the school nurses and the teachers to figure that out.
That's great. That was a nice question. So I know just a question that I've been asked a lot, well, not a lot, a couple of times because of the recent guidance was regarding the flu vaccine and the fact that we all know that students are now required, now medical exemptions and religious exemptions aside here, they are required to have a flu vaccine before, I'm sorry, a flu shot or a flu by the 31st of December, so the end of the year. And without getting into a discussion about the merits of it or not the merits of it, I just wanted to ask, how would they go about doing that? And I wasn't exactly clear on what the age cutoff was for going to a pediatrician and then going to one of these flu clinics. And I know, Mary, we're hoping to have a flu clinic in town here. I don't know if it's time you could talk about that a little bit, but any advice on that? And just so parents are really aware about how they should go and get a flu vaccine. And maybe I'm a negligent parent because I have 4 kids and I'm not really sure. My wife takes care of it, so I'm trying to get a sense for what people know and don't know.
So I can speak to that. Currently, we are in the process of setting up 2 drive-through clinics and 1 in-person clinic. The dates have yet to be decided, but the drive-throughs will be at the Osgood School. And then the in-person clinic will be at the Deer Hill School. Also, I would just say, 80% of children in Massachusetts receive a flu shot. So that's really good. I feel like we're ahead of the curve on that. I would advise parents to either call their pediatrician or their family practitioner and see if they can get their flu shot there. The other thing that's good to know is that CVS, Walgreens, and Stop and Shop have all lowered the age this year of vaccination. So they will do children 9 years and older. So that's another option for people. So I think we'll have plenty of options to get that flu shot.
That's great. Wonderful. Well, we're actually at I have one more question here. I'll take one more. Following up to the question about who might need to be quarantined following a positive confirmed case. Are you keeping kids 6 feet apart at recess? Yes, we are. If a child tests positive, theoretically, would any other child need to be quarantined that is in the same class, some playground, etc., as the child who tested positive? Well, we would be mindful of that, but yes, we are keeping them separated and with their class when they do go to recess. So we would obviously look at that, and we do. In lunch, we have and this is mainly a session for elementary, so we do have our kids separated. They're separated 6 feet apart. So we really shouldn't have a scenario where, a bunch of kids are exposed at either of those activities. But we'll be looking at that possibility and making sure that we record if they are. So that's a really good question. Anything to add to that, Dr. Golden or Mary?
Not really. I think you nailed it.
Okay. So at this point, I'll stop because I don't have any more questions, and it's just about the hour. And we will be back tomorrow night because I realize that this is an important matter. And although it might be maybe a brief session, depending on the questions that are there, folks who were at the session and have additional questions can certainly come back to that one, as can our middle and high school population who may have questions regarding their students. So in closing, I just want to thank Dr. Golden very much. I want to thank Mary very much. Thank you for all the work you do to help everyone in our community. And thank you all for tuning in. This recording will be placed on our website. And we'll see you again tomorrow night, Dr. Golden and Mary. We'll have more fun, answer questions. So thank you.
Thank you.
Thank you.
Thanks, everyone. Have a great night.